This is a video in clinical medicine from the New England Journal of Medicine.
Female urethral catheterization, the insertion of a catheter through the urethra into the urinary bladder to permit drainage of urine, is a fundamental skill for the practicing healthcare professional. This video discusses the indications for catheterization, the equipment available, the current methods of catheter insertion and maintenance, potential complications, and how to troubleshoot common problems. Female urethral catheterization is indicated for both therapeutic and diagnostic purposes. Urinary catheterization is therapeutic in several circumstances. It permits effective bladder drainage in patients with acute or chronic urinary retention. A urinary catheter may be used to instill medication for local intravesical therapy. Urethral catheterization and irrigation may be used to remove blood and clots from the urinary bladder in patients with gross hematuria. Urethral catheterization facilitates diagnosis in several circumstances, such as obtaining sterile urine specimens for urinalysis or culture, measuring post-void residual volumes, and monitoring urinary output during surgery or in critically ill patients. Catheterization also allows installation of contrast media during various imaging procedures, such as voiding cystourethography and retrograde urethography. Suspected or confirmed urethral injury can be a contraindication to catheterization. Urethral injuries are rare and are most commonly a result of pelvic fractures or multisystem injuries. If blood is found at the urethral meatus, or if there is evidence of gross hematuria or a perineal hematoma, then urethral or bladder neck injury should be considered. If there is any question of injury, both genital and rectal exams should be performed, and retrograde urethography considered before catheterization is attempted. In this setting, consultation with a specialist prior to catheterization, if feasible and if time permits, is prudent. Patients who are unable to cooperate may require extra time for calming, or may even need sedation for the procedure. Consultation with a urologist should be considered in patients with a recent history of urethral or bladder surgery. Since urinary catheterization can cause infection or trauma, this technique should not be used for routine management of urinary incontinence, but should be reserved for circumstances in which non-invasive methods fail. A variety of pre-packaged urethral catheterization kits are commercially available. A typical kit includes a water-absorbent underpad, a sterile fenestrated drape, sterile gloves, 4 or 5 swabs, forceps, an antiseptic solution, a 10 cc syringe pre-filled with lubricating jelly, a 10 cc syringe pre-filled with sterile water for balloon inflation, a pre-connected closed Foley system, and a specimen container with cap and label. Other items, such as those for securing the system to the patient or the bed, may need to be gathered separately. There are many types of catheters varying in construction material, design, and size. Catheters are most often made from latex. However, the use of silicone catheters is becoming more widespread, as latex hypersensitivity and even anaphylaxis related to latex are increasingly recognized. Silver alloy hydrogel-coated latex catheters may decrease bacterial colonization and growth and should be considered for patients with recurrent infections. The Foley catheter is most frequently used in female patients requiring an indwelling catheter. It is a double-lumen, straight-tip catheter with a balloon at its end that is inflated after insertion into the bladder to help retain the position of the catheter. Other types of catheters include the triple-lumen catheter, which can be used for continuous bladder irrigation after bladder surgery or for patients requiring irrigation to prevent retention of clots within the bladder, and the straight catheter, which may be used for intermittent catheterization or on a one-time basis to obtain a urine sample. The size of the catheter is categorized most frequently in French units, circumference in millimeters. The narrowest and softest tube that can effectively be used is recommended, thereby limiting discomfort and decreasing the risk of infection. Smaller catheters are used for narrow urethras or in patients with a history of strictures or scarring. 14 French to 16 French catheters are appropriate for most adult women. Larger catheters, 18 to 24 French, may be used in patients who are at risk for obstruction of the lumen, for example, patients with gross hematuria with clots.